అట్లా
పవన్ మ్యూట్ చేసుకోవా?
RFP, I'm on mute only. Yeah.
Yeah. Can I?
Yes, Dynamic Secretary.
Yeah,
Go ahead.
now we are live. Handing it over to Dr. Sridhar. 1 second. Dr. Nitin, please stop sharing of screen.
Okay, sir.
Yeah, Dr. Sridhar, please.
Yeah. Good afternoon, everyone. This is from Indian Academy of Pediatrics, Twin Cities branch. We are coming with Pac-Man series, which is a very much important to all the practicing pediatricians and the postgraduates to refresh their acute emergencies and all the need of the practice. You can go through the things. Now, the first episode is how to read the ECG, how to catch hold the diagnosis in the ECG without the help of the cardiologist, and referring the case commonly with SVTs and AF. We can diagnose the blocks, we can diagnose the ECGs. This is the first episode. And now I request our president, Sugunakar Reddy Garu, to say few words.
Good afternoon, Sridhar. Good afternoon, Dr. Pawan, Dr. Nitin Chawla, and Dr. R.S.V. Sri Krishna, and Dr. Sri Krishna, Professor of Pediatrics from Apollo Hospital. So, after we have launched this Pac-Man series on 14th July, and today is the first episode of the Pac-Man series, and all the interesting topics are going to be covered. This session is going to be held every fortnight from 3 to 4:30, and today's topic is the ECG, pediatric ECG monitoring. And I request Pawan and Nitin Chawla to supervise, to sort out the topics and intimate it well in advance. So I wish all the best for Pawan and Nitin Chawla, and I hope this program is already enrolled by already more than 1,500 people, and I think this should be a grand success. And after the end of the program, you are going to be certified by the Royal Australian College of Physicians, which is going to be useful for your future careers. Thank you.
Yeah. Thank you, sir. Now, really, the rocking personalities of our program: one, Dr. Pawan; second, R.S.V. Sri Krishna, our treasurer; and Dr. Nitin Chawla, and guided by our best professor of pediatrics, Dr. Sri Krishna sir Surampudi from Apollo. He is the head of the department from Apollo. So there's a beautiful team, sir. We are including all the best speakers in the Twin Cities and across the India, pan-India. So that pain will be taken by Pawan and Nitin and RSV. And you kindly guide the team to give a best output for the Pac-Man series. So I hand over the stage to Pawan and Nitin and Sri Krishna sir and RSV. Go ahead. All the best.
Sri Krishna sir, please share your comments, sir.
Am I visible, no?
Yes, sir.
Okay.
Yes, please go ahead.
A very good afternoon to all, and a happy Independence Day. And today we are going to start a really excellent session, one of the very, very important session for all pediatricians across the country, not only that, even across the world also, those who can constantly listen all these things. This is a session. Actually, now the Zoom meetings are the day nowadays. Most of the theoretical part we learn in Zoom meetings. Then it's essentially when the topic is about the pediatric acute and critical care expert course, and obviously you are not going to learn completely on listening the theory lectures also. So this course is a 6 months course designed. Initially, we cover all theoretical aspects by the experts, and it's a very systematic. I've gone through the lectures also, even the persons who are going to give lectures are really wonderful people who had a good experience in managing the critical care cases. And after, if you complete this 6 months course with almost all the topics, there will be a small exam also you will conduct, and based on that, and you will be eligible to get certificate from the Australian universities. So it's a not only regarding the certificate, but it's these particular topics are making you to be experts in critical care. So for this, the today topic, first we are going to have how to read pediatric ECGs. Generally, pediatricians are always run away from ECG, but it gives a lot of information, and it is easy also to detect many important aspects, so that even we can treat. The pediatricians can treat, not that cardiologist. So in that, how to read the pediatric ECG, that is ABC of pediatric ECG by Dr. Nitin Chawla. Actually, this course is basically initiated by Dr. Nitin Chawla and coordinated by Dr. Pawan. I appreciate everyone, Dr. Pawan, Dr. R.S.V. Sri Krishna, and especially TCB President and Secretary, and more so Dr. Nitin Chawla. Let us start the session, and we'll try to start by exact time, and we'll try to stick from next to the times from next time onwards.
Yes, sir. Sure, sir.
Thank
Thank
you. Yeah,
Thank
Pawan, Pawan, just one suggestion before we begin. A warm welcome on behalf of IAP Twin Cities branch to all the audience. YouTube is very interactive now. As you watch this session, please share your comments, thoughts, and if there are any points which you would like to raise, share it in the chat box on YouTube. We have moderators who will be looking at these comments and responding back as the time comes, and also at the end of the session. Over to you, Pawan. Please take it forward now.
Yeah, thank you, RSP, for being instrumental in starting the program as a key technical person. So my humble salutations to our beloved President Dr. Subnakar Reddy sir, and the Dynamic Secretary Dr. N.L. Sridhar sir, for accepting and starting this wonderful program. The Pac-Man has become like a hit, like Superman across the country and across the globe. We have participants across the globe now. So as a healthcare professionals, we know that pediatric patients, they present with unique challenges, and accurate diagnosis is crucial for effective treatment. A pediatric ECG, we all know that it's a non-invasive, painless test that measures the electrical activity of the child's heart, and it is an essential tool for assessing the cardiac function, detecting potential abnormalities, and guiding the important management decisions. So today we have an esteemed speaker, I think Nitin Chawla. He is the person who is instrumental in bringing this program to IAPTCB. So we have to learn about this important aspect. Let's explore the nuances of pediatric ECG and its application in the office practice. Being the practitioners, it's important how pediatric ECG is essential, because sometimes the patient get to our practice. We have to know at least now that how to communicate them, and ensuring we provide the best possible care for our young patients. So with that, I request Dr. Nitin Chawla sir to start the program.
Thank you, sir. I'm sharing my PPT, and before the load is happening, I would like to thank all the dignitaries who have given me this opportunity to present and bring this bring this thing to work. And I believe when we talk about ECG, they tend to be I think the screen. I would like to thank. Yes. Dr. Subnakar Reddy sir, Dr. N.L. Sridhar sir, Dr. R.S.C. Krishna sir, Dr. Pawan sir, and Dr. Shri Krishna sir, your guidance is utmost needed for all of us. Without wasting much time, I'm Dr. Nitin Chawla, and today's topic is ABC of pediatric ECG. I hope my screen is visible. So,
yes, sir, it's visible. Go ahead,
great.
sir.
I'm dependent on the age of the child. So by that, we have to understand that a child who is 16 years of age and a child who is 16 days of age, heart rate of considering 150 is abnormal in 16-year and is perfectly normal to some extent in a child who is 16-day-old. With this background, we should reinforce on the basis of pediatrics that children are not small adults. So we have to forget our concepts from internal medicine to have open mind and learn about pediatric ECG. All of us know that the pediatric ECG measurement is done through chest leads to limb leads. There are technically 14 leads which are at one point of time applied on the child and to see all across. The two limb, we define them as per the vectors, and on our ECG lead or our ECG paper, technically we get lead AVL, AVR, AVF, lead 1, 2, 3, V1 to V6. These are very important for theory, but in practical aspect, to make your life simple, today I'm going to tell you which are the right leads which you should always think about, which are the right leads which you should leave. So in a nutshell, the right side of the heart, the leads which explain clinician about what is happening electrophysiologically inside heart, is showcased by AVR, V1, V3 and V4 are, if they are applicable, to make it 14 lead. If not applicable, then don't. Otherwise, AVR and V1 are the most important leads which tells you about what is happening in the right side of the heart. For the left lead, that is the left side of the heart, lead 1, AVL and V6. For inferior surface, the base of the heart, we are able to understand through lead 2, lead 3 and AVF. Apart from all above leads, from V2 to V5, most of the time, most information is received from V1 and V6. So if you want to focus your energy on V1 and V6 and all other leads, AVR, AVL, lead 1, lead 2, lead 3. If you keep these leads into your mind, you're not going to miss anything. Now, when we talk about missing anything on ECG, we should understand that ECG is calculated on a paper which is specifically divided into grid, like the paper which the example of the paper is in front of you. There are considerations which a clinician should make before we jump to conclusion. Most important aspect is speed at which the paper is set. Usually the speed is 25 millimeter per second. So if you see, one small box is equal to 0.04 second, and one large box is approximately 0.04 into 5 small boxes, that is 0.2 second. And like this, 5 large boxes is equal to 1 second. So this 1 second is the enough amount of, in your ECG which you hold in your hand, is like 2 to 3 second reading, where it is telling how the heart and electrical waveform is happening in the heart. Second important concept is calibration. Calibration means at what level your lead size and the reflection of ECG finding will be shown to you on the ECG page. If your calibration is not correct, then you may see that all the waveform are shooting out of the pages, and in chest leads, it might give you an impression that there is hypertrophy. So what is this, where we can see what is the speed, what is the voltage at calibration, where how this ECG has been taken. In every ECG, like in this, we can see 1, 2, 3 AVR, AVL, AVF, V1 to V6 and a long lead V1. Below this, to step by step, if you want to read ECG, start by reading name, age, gender of the child. Then go down and see what is the speed, what is the voltage, what is the calibration with which this ECG is taken. Have a visual impression of this ECG, because this is a full standard calibration. When we talk about full standard calibration, now when we talk, just visualize full standard calibration with 10 millimeter per microvolt, which is shown on the y-axis. Now when we go to half standard calibration, you can see that everything is dampened and speed is remaining the same. So this, in the extreme corner on the ECG waveform, we have a rectangular box which is equivalent to the size of every waveform. That is the way calibrations look like. In the half calibration, the box which is at the end is in half. This calibration is important to make a decision whether there is any restriction in generation of waveform, and pathologically if there is pericardial effusion or pericarditis. Then also with normal calibration you will see dampened waveform recorded on electrodes. Why this is important? Because in pathological formation, in pathological conditions, all the dampening of electrocardiographic activity is seen. And if you know this basic, then you are not going to overdiagnose pericardial effusion or pericarditis, but you will rectify the calibration. When we talk about ECGs, ECG are very good to understand what is the rate, whether there is tachycardia, whether there is tachyarrhythmias, what is the excess, whether this is an abnormal excess for this specific age, what is the interval, whether QT is prolonged, not prolonged, whether there is right ventricular hypertrophy or not. When we talk about left ventricular hypertrophy, then ECG are not that great, and there is a possibility that you may not decipher entire information from ECG. ECGs are not the best way of giving you information about Q wave rhythms and ST changes. To some extent, even we say QTC is calculated well, but we have to go in detail with ECG and other electrophysiological studies to confirm QT prolongation, and corrected QT intervals are calculated, but further evaluation need to be done to diagnose and confirm. When we talk about ECG as a waveform, in a normal ECG, P, QRS, T, everything is visible. And when we talk about the machine, these values are not all the time correct. So always cross-check with the scale, which we are going to teach you over the time. And we should understand that whenever we are looking at any ECG, we should always check the demographics. Second is speed. Third is calibration. Then we go to the leads, limb leads and chest leads. So limb leads are 6. They are lead 1, lead 2, lead 3, lead AVL, AVR, AVF. Now in these limb leads, these are 5 parameters in which these limb leads are very helpful. Today for this ABC of ECG, I'm going to go in the initial 45 minutes, I'm going to go and make you understand how to read an ECG, and then we are going to discuss on normal ECGs in ER which we should diagnose, and if time permits we'll go to normal ECGs which we can do in clinics. When we talk about rate, simplest formula, simplest way is to understand that a small square is 0.04 second and one large square is 0.2 second. So there is a method called box method, where between RR we have to divide 60,000 divided by RR interval in milliseconds. This is called as box method. The other method, the interval method. The box method says take number as 300, between the 2 RR interval divide by number of large boxes, or 1500 divided by number of small boxes. By this you will be able to understand heart rate of the child. Now this heart rate, as we know that if in an infant heart rate is going beyond 220, we should start thinking about SVT. If age is beyond infancy, then heart rate more than 180, again we should start thinking about SVT. Now if it is below 60, then we start thinking about bradyarrhythmias, bradycardias as well. So understanding heart rate in an objective format is equally important. Most of the time we tend to look at the ECG and we make an impression, yeah, this is heartbeat is more. If we start quantifying it by actually spending 30 seconds in calculating, that will make our life easier. Second, and the most difficult in most of circumstances, is understanding axis. Not only QRS axis is important, P axis is equally important. P axis tells us about atrias. QRS is mainly telling us about ventricles. Leads which are important to understand what is the axis are lead 1 and lead AVF. You can forget all other leads for the moment. Focus on these two leads. So again, I will reinforce, check demographics, C for speed, do calibration check. Now see what is the heart rate. You can do it in lead 2. When you tell about axis, you should focus on lead 1. And from limb leads, another lead which is important is AVF. For axis, we should remember that P axis in lead 1 and P axis in lead AVF is range between 0 to minus 90 to minus 180. So in this format, a normal axis is when the lead 1 and AVF are positive. It is called as normal or high RA rhythm. If the axis is positive, if the waveform is positive in lead 1 and waveform is negative in lead AVF, then it is a low RA rhythm. If waveform is negative in lead 1 and negative in AVF, then it is a low LA rhythm. And similarly, if it is negative in lead 1 and positive in AVF, high LA rhythm. With examples, let us now see. In this ECG, we will see that for a child of 9-year age, heart rate is, we will go to heart rate, speed is 25, calibration is okay. Now to understand the P axis, we focus on lead 1 and also we focus on lead AVF. We can see that preceding QRS has a positive deflection in lead 1 and a positive deflection in lead AVF. Thus, we can say that it is high RA or a normal axis for 9-year-old. Similarly, in this child, again we will see lead 1, lead AVF, speed, calibration. For the similar child, we can see that in P wave in lead 1 is positive, but P wave in AVF is negative. So we can know now that this axis is abnormal. Why we are trying to understand that this abnormal axis is there? Because these children who have an abnormal atria, who have an abnormal axis, are more prone for arrhythmias. They are the children who have some defect at the level of vasculature level when they are interacting with cardiac tissues. This ECG gives you enough time to finalize that echo is necessary immediately, or you can book an appointment or send them to a tertiary center or to another area or district to get an echo done. Other axis which is important, again which will be picked through waveform in lead 1 and AVF, is a QRS axis. So QRS axis, in this diagram, you can understand that a positive deflection of QRS in lead 1 and AVF comes into 0 to 90. With positive in lead 1 and negative in AVF, you go in an abnormal zone of 0 to minus 90. When it is negative in lead AVF, negative in AVF and negative in lead 1, it goes into minus 90 to minus 180. The QRS axis, when we talk about QRS axis, it is considered normal between 0 to plus 120. And always remember that if the deflection of QRS is negative in lead 1 and is negative in AVF in pediatrics, it is abnormal. It is called as northwest axis or superior axis, and it is usually associated with this left axis deviation is abnormal in pediatric age group. For example, one lesson from this slide is quite visible that it is never normal in pediatric age group. If you see a QRS which is negative in AVF, you are dealing with something which is abnormal. Most common reason of left axis deviation is AV canal, which is partial or complete, tricuspid atresia, WPW syndromes, single ventricles, left anterior hemiblock with or without left ventricular hypertrophy. So these surgical interventions or insertion of defibrillator with rhythm generators will be needed if you are looking on ECG with a negative QRS in AVF. So again, with one ECG, you can decide lot many things. And here we all understand that we have not gone to the core presentation of ECG, which we have been looking all this while. We have not touched lead 2 yet, but still we are able to understand that there is a possibility of a surgical intervention and a congenital heart disease, which is seen on this image, on this infographic, which is in front of you right now. With example, let's see, when we have to go for systematically speed, calibration, P-axis, QRS axis. In this QRS axis, in lead 1, it is positive, but when we see lead 2, lead AVF, it is negative. When we say negative QRS axis, so considering the baseline of ECG, we check for positive and negative deflection, and we come to a conclusion by subtracting the negative deflection from positive. If the end result is positive, it is in positive axis. If the end result is negative, it is in negative axis. So the maximum height below and above the baseline will define whether this is positive or negative. In this ECG, it is a left axis deviation. And again, for 5-year speed and calibration is not, so I want all of you to focus on lead 1 and AVF. We see that P-axis is positive in lead 1 and AVF, but QRS axis is negative in lead 1 and also is negative in AVF. So we are dealing with left axis deviation, specifically northwest axis. Now, when we talk about northwest axis, we have seen that this left axis deviation is seen in canal defects, pathological arrhythmias, left ventricular hypertrophies. Third thing which we should remember is normal sinus rhythm is also picked by limb leads. What are these normal sinus rhythm? Normal sinus rhythm has few characteristic features, which are a normal P wave axis, that is a positive P wave in lead 1 and AVF should be there, where we called as high RA rhythm. Every P wave, that is one P wave, should have one QRS associated with this. There should be a fixed P wave morphology. It should not be a tented P wave or a extended P wave, but a uniformity in P wave is seen. And the PR interval should be constant. So fixed P wave morphology, fixed PR interval, fixed association between P and QRS, and a normal axis is called as normal sinus rhythm. When we deal with limb leads on ECG, we have to ensure that we go step by step. Speed, calibration, P wave axis, QRS axis, then we check normal sinus rhythm. So for normal sinus rhythm, you can see that both the P wave morphologies are normal. Axis is in right atrium, is in high RA, that is normal rhythm. Each P wave is associated with QRS. Morphology is constant. So we can say that this is a normal sinus rhythm. In this, again, we will see lead 1, lead AVF. We check that P wave is positive in lead 1, but it is negative in lead AVF. And when we talk about axis, P axis, it is low RA rhythm. And we can say that this child is not having a normal sinus rhythm. This one line information of normal sinus rhythm will ensure you as a clinician to refer this child to a cardiac center which can manage this child. And you see in this ECG, this child is a 7-year-old. Relevance of picking arrhythmias or rhythm disturbances in ECG is very important in today's scenario, when we all know that every month we get 2 to 3 reports of someone having sudden cardiac arrest while dancing, while singing, while doing a celebration, while running, while playing. This is one of the cause. Rhythm disturbances are one of the cause to have the sudden cardiac arrest. And we as clinicians have this responsibility to pick them early, in which ECG are of great help. For this 11-year-old, again we go in the same way to check for speed, to see calibration, to go for P axis in 1 and AVF, to look for QRS axis in 1 and AVF, and then to go for normal sinus rhythm or not. So here we can see that in 1, sometime P wave is positive, next time P wave is not there. In AVF, sometime P wave is negative, sometime P wave is positive. This type of different P wave axis and P wave morphology is usually seen in wandering pacemakers, where some part of atria is generating rhythm, and again that same part is not generating rhythm, or the flow of electrical current is disturbed. Most of the time, these children, if young, at 11 year, will feel palpitations. Next, in limb lead information is P wave and PR interval. So we have used lead 1, we have used AVF out of limb leads. Now we are going to use lead 2, which is favorite to all of us, or most of us in our post graduation have ordered long lead 2 ECG. Now let's see what all we can take out information from this long lead 2. So P wave and PR interval are two important things which we are going to make out. A normal P wave looks like this, where we have each QRS comprising each box of 2.5 into 2.5 will cover the entire waveform. When we talk about P wave, the height, if it is more, then it is called as P pulmonale, and length of the P wave, if it is more, it is called as P mitral. P pulmonale, that is tented P wave, that is the length and breadth of P wave. If it is going away from 2.5 into 2.5, then it is abnormal. In the second picture, we can see that the P wave is flattened up and is prolonged. That is a P mitral. If the tented P wave are seen, then it is P pulmonale. P pulmonale is suggestive of right atrial enlargement, and P mitral is suggestive of left atrial enlargement. Most of the surgical causes, most of the vascular abnormalities associated with heart, which need surgical intervention in infancy, have this kind of P wave morphology. And lead 2 is very supportive in evaluation. So we are focusing entirely at this moment on lead 2. And again, we can see that the P morphology of P wave in these lead 2 and its relation with the other waveform is very significant. If you go systematically, you're not going to miss on anything. So when we talk about lead 2, for this slide, focus only on lead 2. Check P wave morphology. If it is going beyond 2.5 boxes in length or in height, it is an abnormal P wave axis. Second part, which we should understand what lead 2 tells us about this PR interval. Now PR interval, regardless of age, it is normal between 2 to 4 small squares. One square being 0.4 second, 2 to 4 small square means 0.8 to 0.16 second. When we talk about prolonged PR interval, it is the first degree AV block, which is usually missed. But if we know where to see and what to see, we are not going to miss it. Most commonly, it is seen in repaired tetralogy of Fallot, and very commonly it is seen in atrial septal defect. Recently in our OPD, we have seen one 21-year-old coming to pediatrician because he knows the pediatrician. Only one finding which was atypical was this: she was having recurrent headaches and was having first degree AV block. On PR prolongation was there. On echo, there was 8 mm ASD, which was undiagnosed till now. This slight prolongation from more than 0.8 to 0.16 second is relevant enough. Similarly, a short PR interval that is less than 2 square is seen in Pompe's or WPW syndrome. Last in limb lead information is Q wave. Now Q wave are important enough in pediatric also. It does not always means infarction. They should be always be looked in lead 3. So we have taken lead 1 for P and QRS axis. We have taken lead 2 for PR interval for P wave morphology. And now we are taking lead 3 to check about Q waves. Q waves are normal in inferior leads, which are depicted by AVR and V6. For normal Q wave, they are represented by 1 box wide and 5 box height. So 0.4 second in width and 5 millimeter in height. If at all you see Q wave, which is seen before a deep Q wave, or even presence of Q wave in lead 1 and in lead AVL, this is Al-Kappa. And Al-Kappa is a medical emergency. Al-Kappa is a vascular abnormality where the pulmonary artery, the circulation is deficient. I'm going to show you the ECG next slide. Wide, that is more than small square in the base, and deep, that is more, height is more. It is wide Q wave is seen in infarctions, which is a complication of Al-Kappa. In pediatric age group, it is the only known entity to cause myocardial infarction. And deep Q wave are seen in left ventricular hypertrophy. So here we should see that Q wave, when seen in lead 1, in lead 3, are considered as abnormal if the length is more than 5, and thus it is called as left ventricular hypertrophy. When we see positive waveform, positive Q wave or Q wave in lead AVF, then we should start thinking about Al-Kappa in such children. At least we should do an echo. We should understand that echo is going to guide further about existing MI because of Al-Kappa, and will involve our pediatric cardiologist and cardiovascular team to take care of the child immediately. For a 4-month-old, information on lead 3 with P wave being Q wave being more than 5 squares, and if you can diagnose LVH and at this age, that means you are quite helpful in understanding and identifying an etiology which needs either surgical correction, can be coact, can be hypoplastic left heart, can be aortic stenosis. So, my dear friends, understand that simple infographic of ECG gives you abundant of information. There is lot, like on this very ECG, we can see many waveforms. Go focused. Do not rush. Here, if you see, the people have asked for long lead V1, long lead V2, long lead V5. If you see, this type of ECGs are also seen in certain institutes. But for step-by-step process with speed, calibration, lead 1 AVF for P wave morphology, lead 1 AVF for QRS axis QRS. Here we can see that in lead 1, the axis of QRS is negative in lead 1 and is positive in lead AVF. So we are looking to an abnormal QRS axis. When we talk about lead 2, we have to talk about normal sinus rhythm, PR interval, which seems to be there. But if P wave morphology is abnormal, then we are not dealing with a normal sinus rhythm. And here we can see that in AVL, there is Q wave presence. So this will help us to identify that whether we have to go further for evaluation and involve our team quickly or not, because if at all this is Al-Kappa, then we are dealing with something which can be detrimental to this child's age. Coming from limb leads, now we go to basics of chest leads. I'll try to keep it quick so that by 4 we start our cases. So chest leads, we have T wave, which we are going to see in V1 and V6. And in lead V1 and V6, always remember that T waves should be positive in less than 1 week and in adolescents. From 1 week to adolescent, T waves will be negative in V1, and thus we should not be worried if we see a negative T wave in lead V1. Normally in 1 day old, in this ECG, you can see that T wave is positive in lead V1 and V6. In comparison to that, at 3 months, T wave is negative in lead V1, but it is still positive in V6. Just see this ECG again. It is positive in lead V1. It is negative in lead V1 at 3 months. These both are normal T wave in a child, and this is the information which lead V1 and V6 tells you about for T wave morphology. Second thing, again, the same normal T waves at different age forms, where we have said that once adolescence has started, again T wave will be positive in V1 and it will always remain positive in V6. When you understand a positive V1, positive T wave in V1, you will easily pick a negative T wave. Now, at age of 3 weeks, if you see a positive T wave, then that means if it V1 T wave is still positive, that means you are dealing with something which is not correct, and you evaluate this child quickly. Here we have got a T wave which is technically flat, and we can, on evaluation, we will go and understand that there is right ventricular hypertrophy. Chest leads are good to tell you about right ventricular hypertrophy, and ECG per se is okay to tell you about left ventricular hypertrophy. Again, stay focused and see. Now our focus is on chest leads. T wave is positive in V1 and it is negative in V6. So if a positive T wave at 7 months is seen with a corresponding negative T wave in V6, we should start thinking about getting an echo done and see whether we are right in diagnosing it right ventricular hypertrophy in this child. Now we know various surgical causes, various cyanotic heart diseases will have right ventricular hypertrophy. If one ECG we can identify that there is something surgical ongoing, then you all know that you're going to save this life. Second information which we should focus upon is RS-R' pattern, again which we are going to see on V1. Now, when we talk about RS-R' pattern, it is very common in pediatric. Sometimes it can be normal. Other time, this gives us information about right ventricular hypertrophy. And the same pattern also tells us about right bundle branch block. So why one RS-R' pattern gives us so much information? That all depends on you are looking RS-R', rabbit ear morphology, and how is this RS-R' pattern, which is technically the QRS duration, and what all is it going to tell you? So if you see that QRS duration is having RS-R' pattern, that is a positive deflection of R, then a negative deflection of S, then again another positive deflection of R'. If you see RS-R' pattern in V1, QRS duration once measured, and the duration of QRS is 2 small square, and this duration is more than 2 small square, that is more than 0.9 second, then you're dealing with right bundle branch block. If you have a RS-R' pattern where the height of second R, where the duration of RS-R' pattern, that is QRS duration, is technically less than 2 small squares, and also the height of second R dash, that is the second positive deflection, is more than 10 mm, then you're dealing with right ventricular hypertrophy. If the first R is taller, then probably you are dealing with something a normal variant of a heart. So QRS duration in V1, T wave in V1. These are important consideration. T wave before T wave from till 1 week and after adolescent will be positive in V1. When we talk about QRS duration, we should see what is the pattern of RS. If it is RS-R' and QRS duration is more than 2 small square, we are dealing with something called RBB, right bundle branch block. where we are seeing RS R dash pattern. If QRS duration is less than 2 small square and the height of second R waveform is more than first, that is R dash is taller than R and is more than 10 millimeter, then we are dealing with right ventricular hypertrophy. If it is less than 10 mm, probably we are dealing with a normal variant. Here, to make you understand, we have 6-year-old with a negative T wave, with a positive R, with S and R dash. And you all can see that the height of R dash, duration of QRS is for the normal variant. The R dash is less than 10 mm. And this is a normal ECG, normal variant. In comparison to that, if you see V1, the second limb of QRS, which was having a RS R dash pattern, second R dash is smaller than first R. In this ECG, you can see that a first positive deflection is small, then S comes, and then the second positive deflection is more than 10 mm. That is more than 10, more than two large squares in y-axis. In fact, here it is more than four large squares. So to keep it simple, remember that R dash duration of QRS with RS R dash pattern is 2 small square or less than 2 small square, and R dash is 10 mm more than 10 mm. That is the second positive deflection is more than 10 mm. Then you are dealing with right ventricular hypertrophy at 16 months. And you have to do an echo to understand the surgical insult what child is going through. Here we are focusing on chest leads. So I'm just putting what are the things you should see in V1 only with clinical determination and how do you plan for ahead. I'm not reading the ECG, but as a dictum, you should always read ECG with speed, calibration, P wave morphology, QRS morphology, PR interval, P wave interval, look at Q waves, and then go to chest leads so that you have a fair understanding. Here again, we have V1 where we can say that in this case, QRS duration is more than 2 small square. R dash, even if it is taller or shorter, it doesn't matter. If duration of QRS is more than 2 small square, we are dealing with I right bundle branch block, because you can see that the pattern of QRS, the waveform of QRS is more than 2 small square. You can confidently say that there is possibility of right bundle branch block in this child, and you evaluate them further. Here also, we can see in V1, the QRS duration is more than 2 small square. In fact, it is 0.12 second, that is 3 small square is involved. Again, when we talk about this, there is a R dash RS R dash pattern where second R dash is way high. But when we talk about prolonged duration of QRS, we can confidently say we are dealing with right bundle branch block. Next thing which is being told again is R and S morphology in V1 and V6. How is it useful? In V1 and V6, we have to see S and R. If the duration, if the S1 and S in 1 and R waveform in 6 is more than 98% of the waveform, then we are dealing with left ventricular hypertrophy. Because ECG are not the best, so we can always ask our cardio colleagues to discuss it and to check echo for such cases, but to have some understanding that maybe there is possibility of left ventricular hypertrophy. If at all you see that in a waveform, it is predominantly S in V1 and predominantly R in V6, there is a possibility that you're dealing with left ventricular hypertrophy. Last, another thing which you can see in ECG, which maybe some people who want to go pro on chest lead and do ECG, then ST depression or elevation, which is more than 1 mm from the baseline, also tells you about possibility of a cardiac complication and need further evaluation. Last in chest lead information is QTC, corrected QT interval. We are going to discuss case wise, but to keep it simple, we need to check whether corrected QT is there, which is normal for age or abnormal for age. So usually we take lead 2 for that. We get a fair understanding of QT prolongation by a simple rule, that is, if you look at the heart rate from start of Q to end of T, and we are going to discuss in detail about QTC. So whatever I'm going to tell, if at all it seems slightly confusing, then don't worry. By the end of this lecture, you will be pro in understanding what is QTC interval and how do you calculate it. So here, if you see that from start of Q to end of T, the waveform is more than half of each R interval, then you are dealing with QTC. That's a crude form. But otherwise, to scientifically, if you want to check what is QT interval, then find a good looking QT on ECG. Make sure that regular heart rate is taken into consideration. Then to measure QT, you multiply the entire distance between start of Q to end of T into 0.04. You measure preceding RR interval, multiply by 0.04, and then apply Bazet formula, so that this corresponding higher heartbeat associated with some effect on QT can be waived off. And Bazet formula gives you the corrected QT. So QT divided by square root of RR interval will tell you what is the QT interval. And age wise, we have QT interval, we have long QT, which leads to various life-threatening arrhythmias, torsades, and various other problems. We also have short QT interval because of drugs. And even recently, we had a child from United States who was on defibrillator, and there was a cardiac device inserted because this child was having a short QT, congenital short QT. So corrected QTC interval calculation is very important for sustenance of life. We can get it done to some extent by ECG, but it needs further evaluation with genetic studies and other studies to confirm or to rule in and rule out other causes of QTC. To summarize how and what to go ahead when you get a ECG in hand, ensure you are checking ECG of right child, right age, right gender. Calibration is 10 mm per millisecond. Speed is 25 millimeter per second. In limb lead, you are going to check for rate. You will tell about axis. You will see for normal sinus rhythm. You will see for P wave interval and PR interval in lead 2, and check for Q waves in lead 3. These are normal. In chest leads, you are going to talk about T waves, RS R dash in V1. You will tell about R and S morphology in V1 and V6. You will see at ST segment depression. And finally, to some extent, you can talk about QTC and corrected QT interval. If QTC looks abnormal in chest leads, you calculate corrected QT interval from limb leads in lead 2 preferably, or wherever you see a regular heart rate and a good Q and a good T. Now we are going to cases in pediatric emergencies. We have 1.5 hours to do this. That's why I'm not waiting, and I hope we will be able to do the justice to all of you who are spending their time. At this moment, it's 3:59, and I believe we are at right time. So what we are talking is something I'm not going to reveal already. I believe most of you are aware of this, what we are talking about. But this arrhythmia has a rapid and a regular narrow complex, and it is a tachycardia. And usual heart rate in infant is 220 to 320 beats per minute, and in older children it is 150 to 250 beats per minute. T wave is usually invisible, and if at all it is visible, it is abnormal in excess and may precede or follow the QRS complex. And then in those circumstances, it is called as retrograde P waves. There are many variety, but the most common is a re-entrant type. So in your YouTube, you can put your answers. What is this ECG? And here we are keeping only one lead without mentioning which lead it is, to tell you that you are here looking at something where you are not able to find a P wave, narrow QRS complex. So we are dealing with supraventricular tachycardia. Usually it is well tolerated in infants, but after some time, if not managed or identified, it may lead or present as congestive heart failure, where child will manifest as with irritability, poor perfusion, poor feeding, rapid deterioration is also noticed. And more than 95% of wide complex tachycardia in pediatric are not ventricular tachycardia actually, but they are SVT with aberrancy. When we say SVT with aberrancy, it can be SVT with bundle branch block with a pre-existing congenital heart disease, or it can be accessory pathway with re-entrant SVT. Usually we talk to them as WPW. For the treatment, if you have identified SVT where the Q wave, where the QRS duration is less than 0.08 second and there is no preceding P wave, and the first step to go ahead in such circumstances is to arrange an adenosine medicine, and by the time medicines are arranged, you can try vagal maneuver. Earlier we used to keep ice bag on the face of the child, but nowadays if at all there is nothing, then you can put a clean cloth with some put it in water and put on the child eyes, considering that maybe it will help him to have vagus stimulation, which will cause some bradycardia. In older children, you can try carotid sinus massage on one side, or you can ask the child to take deep inspiration and hold. If the child is a yoga expert, you can ask even them to go for a headstand so that vagus is excited and this lead to bradycardia. But the treatment to this entity is adenosine. Adenosine will lead to transient AV nodal blockade. It has a very short half-life. Most important thing which we should remember is side effect. It can cause flushing. It can cause bronchospasm, which will be short-lived. It can even lead to cardiac arrest if at all we are not understanding the relevance, and it lead to blockade at AV nodal level, and thus we should be ready with adenosine, and we should be in a position to remember that this has a side effect which can even lead to cardiac arrest if not managed well. Dosage is 0.1 mg per kg, should be given rapidly into the large vein followed by bolus. We can repeat second dose within minutes, and second dose can be 0.02 mg per kg. Maximum up to 12 mg we can give. For first time, we can give maximum up to 6 mg. If supraventricular tachycardia on presentation is with cardiac depression or there is massive cardiac dysfunction, then cardioversion is very important in unstable child who is having supraventricular tachycardia. And in ED, the child may require sedation and anesthesia also. If at all shock or synchronized cardioversion is needed, then it is indicated by synchronizing, and the dosage is 0.5 to 2 joule per kg. Again, this is an ECG where you can see that a regular normal complex tachycardia is seen at around 300 beats per minute, which for any age is abnormal. Once you have identified, you will be able to understand that this child is having arrhythmia, may go into cardiac dysfunction if not managed well. Here the speed is 25 millimeter. Now when we increase the speed to 50 millimeter per second in the same child, this will help us to analyze the rhythm, how the waveform looks like. In this waveform, you can see that everything look clustered together. In 1 second, you are able to see 4 millisecond. The 25 millisecond, 25 millimeter per second is the speed. Now, if you increase the speed of paper, information which you are going to gather will be much more clearer. At double the speed, you can see that there is no P wave receding to QRS complex. And QRS whatever we are seeing seems to be slightly broader than usual. So this probably is SVT, and it could be AV nodal reentry tachycardia. Further, once we have given adenosine, there is reversal to sinus rhythm. Compare it with the list with this ECG. There is no P wave. As compared to this, once the rhythm is achieved by putting adenosine, you can see there are peaked P waves. There is presence of right axis deviation. There are tall R waves in V1, which are all within normal limit for the age of the child. Using ECG to identify and choosing the right intervention is the most helpful way of utilizing it. Again, in this waveform, we all can see that QRS is slightly more prolonged than the usual. Like I've said, most of the QRS when we see is not VT, but it is SVT with aberrancy. In this child, we have antidromic AV nodal reentry tachycardia. On evaluation, this child was shown to have WPW syndrome. When we see this ECG, it is a broad complex QRS where the heart rate is approximately 280 per minute. We can easily mistake this as VT. For now, one liner, most of the broad complex tachycardia are actually most of the broad complex tachycardia are actually SVT with aberrancy. And if child is having underlying morbidity or any sepsis, then only child will present at the end level with VT. Otherwise, mostly if the first presentation in your ED is a broad complex QRS, then also keep window of understanding that WPW can also present like this. When you act on this child after sinus rhythm, you can see that PR interval is not very short. And if you closely look, the upslur on the positive deflection from P wave, from the start of Q wave to QRS, there is a slight slurring of the QRS complex. This slight slurring in the beginning of QRS complex is called as delta wave. Sometimes inverted delta wave is also seen, and when we see in such cases, when we go systematically, we will see that there is rightward excess of plus 90. In lead V1, we will see RS R dash pattern, and we will also see T wave inversion, which is very much normal for age in these children. This is another example of WPW syndrome where PR interval is short. The delta waves, which is the upslurring in the initial phase of QRS, in this waveform, you can see the upslurring of QRS complex is very much visible. This upslurring, in fact, in lead 3 for the third complex, all of you can see that in this zoomed image, there is a slight indentation. This indentation is pathognomic for the delta waves. When you see a delta wave, when you see a broad QRS complex, now you're dealing with something called SVT with aberrancy. We were seeing SVT with aberrancy. Now you are looking at something which has a regular broad complex tachycardia, which is very much uniform throughout. And you can actually see that each QRS is identical to the next one or preceding one. So this uniformity, whenever seen with broad complex QRS, is called as ventricular tachycardia. These ventricular tachycardia are very broad complexes. Mostly there is absence of typical right bundle branch or left bundle branch morphology. When you do 12 lead ECG or 14 lead ECG, you will see northwest axis, that is axis which we have discussed with a positive with the lead 1 and AVF having negative deflection. You might see that P wave and QRS complexes are at different rates. Sometimes AV dissociation is also seen. There are 6 points which are very important and usually not being told. I'm going to discuss them again in further slides, but to make you understand, you should be apprised to what all these concepts are. First concept is capture beat, which occurs when the sinoatrial node transiently captures the beat from ventricle, and this happens in mid of AV dissociation, although QRS duration will remain normal. Second is a fusion beat, which occurs when a sinus and a ventricular beat coincide and a hybrid complex of QRS is developed. Third concept is positive or negative concordance, which happens on the chest lead, where V1 to V6, which are showing positive R, or entirely negative QS complexes, which have no R complex at all. The fourth is Joseph's sign, that is notching of S wave at the bottommost level. Fifth is Brugada sign, where the distance from the onset of QRS complex to the bottom to the least point of deflection of S wave is more than 100 millisecond. And last is RS R dash complex, where we have seen that the second limb, that is R dash, is more than 10 mm. Then we can say that this finding goes more into favor of right ventricular, that we go more into favor of ventricular tachycardia. And if first of the limb is positive, like R is taller, duration is more than 2 squares, and R is taller as compared to R dash, then we call it as left rabbit ear, which goes more into favor of ventricular tachycardia. If R dash R pattern is there and duration is more than 2 small square, and the second limb, that is the R dash, is taller, then we call it as right bundle branch block. This is the usual waveform on chest lead. Uniformity, broad QRS is seen. Also, we can see that most of the complexes are positive. These positive complexes throughout the chest lead are called as positive concordance. If all these complexes are primarily negative, then we call it as negative concordance. These are certain informative and things which clinicians should be aware of when they start telling about ECG in a more justified way to the cardiology friends. So VT, ventricular tachycardia, is a broad complex QRS. On chest leads, if you see predominantly positive waveform, it is positive concordance. Predominantly negative waveform, it is negative concordance. Now when we talk about S wave, that is Joseph's sign, then you see that at the bottommost point where the S wave start deflecting towards the upward stroke starts, there is a slight slurring. This slight slurring before the nadir of S wave is called a Joseph's sign. If you see the R is RS interval, and this RS interval is more than 100 millisecond, then also it is one of the characteristic feature of VT. This is called as Brugada sign. In this ECG, we can see that V1 to V6, we have positive concordance. When we see lead 2, there is broad complex QRS, which is uniform with a norm with one baseline, which is utilized. So this type of VT is called as monomorphic VT. That is, each complex of QRS is of same morphology. Uniform QRS complexes are there. Because we cannot see what is P, what is QRS definitely, then we cannot determine the axis in such cases. When we measure the duration, it is more than 200 millisecond. If we check, we can actually see that before the S wave notching, before the P wave starts becoming positive, this is called as Joseph's sign, suggestive of ventricular tachycardia. Here Again, we are going to see Brugada sign, where the RS dash RS interval is more than 100 millisecond, and fusion and capture beats are seen on the rhythm strip with broad complex QRS of 200 millisecond. Most important thing in ventricular tachycardia is to know whether they are uniform or whether they are monomorphic or they are polymorphic, because polymorphic VT is technically last flag. If not managed well, then ventricular fibrillation is nearby and death is further closer. So if you identify monomorphic VT, act immediately to prevent them from going into polymorphic VT. These signs, whichever we are looking at, are relevant to those clinicians who wish to rule out the confusion in their mind whether this VT is actually VT or it is SVT with aberrancy. In pediatrics, SVT with aberrancy is the most common cause of broad QRS complex. But if it is confusing you, then these points are going to help you. Again, in this ECG, you can see it's a broad complex with northwest axis, with Brugada sign positive, with notching of S wave before Nadir, which is Josephson sign, seen in lead 2, 3 AVF, and also there is a superimposed P wave in AVF. When we say about capture beat or fusion beat, this is the concept of capture beat and fusion beat. In the normal sinus rhythm in lead 2, you can see that the PR interval is approximately 0.15 second and QRS duration is 0.08 second. And both P and both T waves are upright. But when we see in the fusion beat, it usually occurs when a supraventricular impulse causes ventricular activation. And in the fusion beat, this, when it reaches ventricle, then you see that a hybrid complex is generated. In the image, the hybrid complex which is generated in the second wave after second P wave, it appears like a normal QRS complex, and thus it is called as a capture beat. The concept of capture beat is seen usually with broad complex tachycardia and is not considered anything but only is defined as capture beat or fusion beat with a background of QRS complexes. When we talk about VT, just look at this image where you have a monomorphic VT ongoing. This need to be ruled out and we need to be seen with a polymorphic VT. Now a polymorphic VT is something which looks like a sine wave pattern, and you can easily make out that the axis is moving above and below. It is not going in synchrony. This gives you a fair understanding like a harmonica, like a sine wave pattern, and these are being generated from ventricle, from various foci of ventricle, where the QRS complexes are of various rhythm, of various amplitude, axis, and variable durations. Most common cause of polymorphic VT is myocardial ischemia or infarction. In pediatric, if at all multi-organ dysfunction is happening, this is kind of near ending. So if you reverse them with identification, then we are able to save the child in intensive care units. Tosades de Pointes is very specific and is a very specific form of polymorphic VT which occur in context of QT prolongation. It has a characteristic morphology in which QRS complex twist around the isoelectric line. The isoelectric line which we talk about is the baseline where every time waveform comes, and thus will help to judge by physical appearance. You can identify that whether there is a monomorphic VT or is this a polymorphic VT. Even in this waveform, you can see that in long lead 2, QRS complex ongoing has converted into Tosades, where P wave QRS complex, whatever was normally seen in lead 2, has automatically been converted. So this normal looking QRS complex going into Tosades now can be secondary to hypokalemia. Now inverted T waves in sinus rhythm with prominent U wave is a predominant feature of hypokalemia. There can be premature atrial complexes where R on T phenomena is seen, and preceding Q wave will be long. Only point, because we have time constraint, I'm not going in detail on electrolyte imbalances. And only point which I want to highlight is, if there is a normal sinus rhythm on your monitors, all of a sudden you start seeing monomorphic VT. That means cardiac dysfunction has started. But if you are dealing with a child who is on various inotrope, and all of a sudden you notice that there is feed intolerance, now there is bloating of stomach, and there is vomiting or aspirations are increased, and on continuous ECG monitoring, which is usually seen in all ICUs, you see that this child is now having polymorphic ventricular tachycardia with broad complex QRS, then probably you're dealing with electrolyte imbalance. Most commonly, hypokalemia is the cause. This will be the last discussion for next 10 minutes, where we are going to talk about ECG waveform, where the QRS is broad, abnormal in morphology, and mainly it is premature. That is, it is occurring just before the normal sinus rhythm. ST will be discordant with T wave, and there will be associated full compensatory pause. This may or may not be associated with retrograde capture by atria. Those who have worked in ICU have seen this waveform. If you see, the first downward looking arrow is one waveform, then you have a normal, where from the time when RR is written, then you see that from RR interval and 2 times of RR interval, there are 2 things which are written. Just see the morphology, and you can see that first there are 2 normal looking waveform, then an abnormal waveform which is bigger. Then there are 3 normal looking waveform, then there is another waveform which is bigger than the usual complexes. What are these? These are called as premature ventricular complexes, which often occur in repeating patterns. Bigeminy, trigeminy, quadrigeminy, couplet, these are terminology given to premature ventricular complexes. When PVCs are happening after every other beat, they are called as bigeminy. When it is happening after every third beat, if you see the first half of this strip, first 2, 1, 2, third beat, it is called as trigeminy. When it is happening every fourth beat, 1, 2, 3, fourth, it is called as quadrigeminy. When you see 2 consecutive PVC, it is called as couplet. So sinus rhythm with PVC of 2 different morphology, here we can see, then these are multifocal PVCs. Multifocal PVCs are more problematic and usually seen in dysrhythmias or massive cardiac muscular insult secondary to infarction or multi-organ dysfunctions. One thing which we should remember, that discordance between ST segment and T wave is noticed, then mortality is more common in such children. If we see, the pause surrounding the premature ventricular complex is technically equal to the preceding RR interval. And when we see this type of feature, then we are dealing with a full compensatory pause, and it is this pause which is more detrimental. So more PVCs will have more pause, and more pause means less function, and less function means less cardiac dysfunction, more cardiac dysfunction. Like we said, bigeminy is PVC after every waveform, trigeminy is PVC after 2 waveform, and this is quadrigeminy where PVCs are seen after third 3 waveform. When 2 PVCs are happening again and again, it is called as couplet. The problem with PVC is they do not cause efficient ventricular contraction, but electrophysiologically you capture them. And once you capture them, you should know that now the membrane, ventricular membrane is affected, and at cellular level, there is more damage happening and cardiac dysfunction is setting in and contractions are inefficient. Nearing to our end of our presentation, this is another important aspect in rhythm disturbances, that is a narrow complex tachycardia with regular atrial activity more than 300 beats per minute. There is loss of isoelectric baseline. This is pathognomic, a sawtooth pattern of inverted flutter waves, specifically in lead 2, lead 3, lead AVF, upright flutter waves in lead 1 that may resemble P wave, and ventricular rate is dependent on how much AV is conducting. So sawtooth pattern is the usual saw which carpenters use, has a pattern over it, then this is the waveform where you can see that after 2 and 3 there is a top waveform, and there is no not much of a wave any other waveform which is visualized, but a serrated margin with some waves which are very prominently seen and coming at regular interval. This is a fixed AV conduction block where the block can be 2:1, 3:1, 4:1. That means if 300 is the rate from atria, 150 is ventricular rate. If it is 4:1 block, then it is 75 beats per minute. Whenever there is a variable AV conduction, you may see regularity. And if it is a variable, then the ventricular response will be irregular and the ECG might look like a atrial fibrillation. Here we are looking at atrial flutter. When we see at lead 2, you can see a negative deflection. Persistently, there is a background of one waveform which is smaller, other waveform which is bigger, but it has serrated margin and you can actually make a waveform. This is the way atrial flutter with sawtooth appearance is seen. In V1, you will see a upright flutter waveform. In lead in this picture, you will see 2:1 block. That is, one wave is blocked and other is processed through AV node, and this ventricular is beating as around 150 beats per minute. Atria is beating at around 100 and at around 300 beats per minute. If the block is 4:1, the same will go into 75. When there is a variable block, this type of waveform is seen. Sometime after one P wave, there is a positive deflection. When you see this type of waveform, this usually presents lead to into atrial fibrillation. Always remember, suspect atrial flutter when you are seeing 2:1 block, where there is a regularly narrow complex tachycardia at 150 beats per minute. Mainly when you see a consistent heart rate of 150 beats per minute and you are thinking that it is SVT, then this is something which you should keep in your mind. In contrast, if it is sinus tachycardia, there could be and there will be beat-to-beat variability. In AVNRT, that is atrioventricular nodal reentry or atrioventricular reentry tachycardia, usual rate is more than 170 to 250. Vagal maneuver or a test dose of adenosine usually helps in identifying these and help in identification of atrial flutter as compared to tachycardia. This is how a flutter wave is unmasked by using adenosine. And when you see AVNRT, that is atrioventricular nodal reentral tachycardia, it will revert back to sinus rhythm after we give adenosine bolus, because AV node will come back to his usual self after action of this drug. But if it is flutter, then it will actually cause more damage and flutter waves will be unmasked after you have given adenosine. In this waveform, you can see that there is no specific wave which can be identifiable. There is no isoelectric line. There is just chaos. This is ventricular fibrillation, where there is chaotic irregular deflection with no identifiable P, Q, R, S, and T waveform. If this is seen in any of the child, if you see in this case, you have a monomorphic ventricular tachycardia being seen after giving ventricular shock, but preceding ventricular tachycardia, you have a polymorphic ventricular tachycardia. So polymorphic ventricular tachycardia, you have given shock and it becomes into PVCs, or then followed by monomorphic ventricular tachycardia. This is the end stage where the patient is shocked out of ventricular fibrillation 5 times in 10 minutes. There is accelerated idioventricular rhythm where a broad complex QRS is seen and there is no AV correlation. The atria are beating at its own pace and ventricular are beating at its own pace. Very commonly, fusion complexes are seen, capture beats are seen. Like I said, fusion complexes in the previous slides also I mentioned. This is another slide because we are at the end. I'm slightly rushing. I hope you will understand. I'll only take 5 more minutes to end this. We are at 4:29 right now. PR interval for lead 2 we should take into consideration. If it is more than 5 small squares, There is something which is not right. In first degree block, there will be a delay. There will be no interruption in conduction from atria to ventricle. Marked first degree block is present if PR interval is more than 300 millisecond. Marked first degree block with PR interval more than 300 millisecond may have a P wave which is buried in preceding T wave, and this is the morphology which you will look at. Whenever you are in confusion where you are not able to see or make out where the P wave is, you look at T wave. If T wave is carrying this P wave, get a ECG done, have a provisional of first degree heart block, and send the patient to a cardiac center. It is better safe to be sorry. If it is first degree heart block, probably timely intervention and identifying the cause will be of very, very helpful to the patient. P to R, you have to calculate, and normal PR interval should more than 200, more than 5 boxes is your cutoff. Now, if there is a progressive prolongation of PR interval, and finally there is no wave there is no ventricular QRS complex, that is a non-conducted P wave. That non-conducted P wave is called as drop beat. And you should know that the PR interval will be longest immediately before a drop beat. When you see this type of heart block where persistently PR interval is prolonged and finally one beat will be gone, this is called as Mobitz type 1. The PP interval will always remain relatively constant, and PR interval will slightly prolong between first and second beat of cycle, and finally there will be a drop beat. Now this Mobitz type 1 block, the first clue will be that it will happen in cluster. There is progressive prolongation and PP interval will remain constant with nearly normally type 2, where all of a sudden one of the heartbeat will not be there, and this type of block will not have any other clue after P wave. That means you're dealing with Mobitz type 2 block. This ECG tells you that there is no correlation between ventricular waveform and atrial waveform. That is, sometimes P wave has Q wave, sometimes P wave does not have a QRS complex. So there is discordance, and this is complete heart block, medical emergency. Usually need of intra-arterial devices or intra-atrial devices are used to manage a complete heart blocks. With this, I would like to thank all the office bearers of IAPTCB and all of you to give me this opportunity to talk to you.
Yeah, thank you. Thank you.
And I'm very grateful to give this opportunity.
Sir, Suresh Krishna, sir.
Well done, Dr. Nitin. Really a little extensive, but definitely it is very, very useful for day-to-day emergency management of the many cases. The main thing what the pediatricians don't do is they don't take the ECG regularly. That is, so every emergency case needs a continuous ECG monitor. Now we have good monitors also with multimodal monitors covering both respiratory and ECG levels. Here, just as a closing remarks, just one or two as a take-home messages. What common emergencies can be detected by ordinary pediatricians on ECG so that he can start the treatment or refer immediately? Because some of the practitioners also have seen in the group. So what they want, sometimes they may not go into too much of details of it, but at least they should know when to go for ECG. There's also almost second question also. Similarly, in day-to-day OP practice also, they should have an idea that when to go for ECG so that they can pick up the emergencies and at least refer to the nearby hospital.
Sir, for any pediatrician, if the child is small and cannot tell about the symptom, that I will say less than 2 years, if a child is continuously crying, if the child is less than 6 months and is having continuous cry, then this cry, if it is not predisposed to specific organ, get a ECG. And do not rush to diagnose a child on ECG. As a clinician, when you do a ECG, first structured approach towards the limb lead and chest lead is important. If at all you notice that the axis, P axis, that is seen in lead 1 and lead AVF is abnormal, will give you a red flag to send this child to a cardiac center. Then you go to lead 2. If PR interval is more than 5 square, it is a problem. If morphology of P wave is more than 2.5, it is a problem. So my simple ideology over here is go with ECG whenever you have a doubt of organ from where the problem is.
Hello? Hello?
Yeah, sir. Go ahead, sir. Sri Krishna, sir. Chepandi.
Just disconnected, I think, from Nitin's side.
Yes, sir. Sir, am I audible now?
Yes.
Yes. So, in a nutshell, we should get ECG whenever we are dealing with a sick child. Secondly, whenever we are dealing with a child who is not coherent and is not able to explain but is only crying. Now, an arrhythmia can also lead to a crying child. And arrhythmia can only be diagnosed on an ECG. This 1.5 hours will not make anyone pro in identifying arrhythmia, but will definitely make them pro in identifying one of the rhythm disturbance in any of the lead. Lead 1, lead 2, lead 3. If you focus on only this lead, then also you are able to going to pick that this ECG is abnormal. My cardiology friend is handy. Let me take help from him or refer him to him, or let me send this patient or take this patient to my cardiology ward. So in a nutshell, if lead 1 has a P wave which is abnormal, lead 2 has a PR interval which is abnormal, and lead 3 has Q wave which is abnormal, we have to take cardiac opinion. Sort out diagnosis later on. An important aspect in pediatric emergency is if you are looking at SVT, identify it. QRS complexes, identify it by narrow complex. For some reasons, getting disconnected. So QRS complexes, yes, sir. So QRS complexes, if narrow, broad, these are the two life-threatening complication which, if seen, can be treated at ER level. Rest, any abnormality seen should be referred immediately.
On the whole, for every emergency case, take an ECG.
Yes.
Similarly, for any confused case where we are not able to suspect any particular diagnosis, like a excessive crying child or excessive irritable child, always take an ECG. And second thing is, I advise all the pediatricians to make it a habit of looking at ECG first of all, because somehow till MBBS final year and internship, we are all good at looking at ECG. But once that part is over, once we come to pediatrics, slowly they are keeping the ECG aside. So first of all, it should be a practice for everyone. On the other hand, for all intensivists, of course, make it such classes really definitely needed, so that even at bedside also we can diagnose and we can initiate treatment for some of the like SVTs. Even pediatrician can treat it. Over to Pawan.
Yes, sir. That is really elaboratively discussed right from the anatomy and dissecting each and every lead. So that really helps Dr. Nitin sir, because we used to just look at the diagnosis and we used to send to the cardiologist if anything is normal is there. But with your elaborative session, I think how to approach a pediatric ECG in office practice, that you have really given us a boost, and that confidence will definitely helps us in our office practice, sir. Thank you so much, because we have seen this, how this can help us in identifying the congenital heart diseases, monitoring the cardiac treatments and all. And also, especially when the parent complains chest pain and simple things like, whenever there's a complaint chest pain and all, so it could be any reason. We know that we are very confident that the chest pain children may not be a cardiac one or something like that. But getting an ECG will also help us to counsel that you see that, report is normal, so no need to worry. So that will help us in reassurance in office practice. So thank you so much for that elaborative discussion. I think this from basic to advanced, you have covered everything, sir. Thank you, Nitin, sir. Looking forward for more Pacman series questions and, sessions with under the leadership of Dr. Sri Krishna, sir.
Definitely, sir. I will also request all the participants to put in their questions on the group, and we will be taking all the questions if at all we are not able to take here.
Yes, sir. I think no questions in the YouTube comments also, sir. I've seen that. So I think we can have this entire week. We can dedicate the discussion in the group related to ECG and all.
Definitely.
Thank you, sir. Thank you so much.
Thank you, sir. Thank you, Krishna, sir. Thank you, Pawan, sir. Thank you, everyone, for joining.